Psoriasis and secondary skin lesions. Psoriasis. Psoriasis can be defined on one side as a skin disorder, on the other as an autoimmune disease. It's basically considered the cutting edge between immunity and dermatology. We often see psoriatic patients in medical practice because there is the psoriatic arthritis, and it is a spondyloarthropathy very similar to the other one, but is secondary to psoriasis. It's an erythematous desquamatous skin disease that appears in individuals with a multifactorial genetic background that is common with arthropathy for many genes. The desquamation is the real problem of the disease for the patient, because actually not much pain is felt, and itching also is there, but the presentation of the skin is very bad. It's a chronic disease with the tendency to relapse. We have relapsing and remitting episodes alternating between each other. From the histological point of view, it's characterized by hyperproliferation of keratinocytes, mixed with incomplete maturation of keratinocytes and bidermal infiltration by T lymphocytes and polymorphonuclear cells. This is the reason for which some therapeutic strategies are done with drugs that trigger the maturation of keratinocytes. Keratinocytes actually need time to reach the surface of the skin, and if they will go too fast, they will be immature, and this is due to an autoimmune reaction with T cells at the basal layer of the skin that triggers this keratinocytes hyperproliferation. So basically, to sum up the general view of the process, the disease is given by these immature keratinocytes that reach the surface of the skin, but the real trigger of this keratinocytes hyperproliferation is the autoimmunity created by T cells in the basal layer, and to some extent also by polymorphonuclear leukocytes, not normally present in the skin. Prevalence. Psoriasis is quite common. The incidence is up to 2% in the world's general population, and so it's common as rheumatoid arthritis. In some areas of the US can arrive up to 4.6% of incidence. The prevalence is higher in Caucasians, while very low in African Americans and Asians. Males and females are equally affected, and the onset of the disease may occur at any age. Generally, the first signs of the disease are around the 30s, and there are two peaks between 30s and 50s. There is also psoriasis arising in children, even if the presence is much lower and the mean age of onset is between 8 and 12 years. It's really rare to have an onset of psoriasis in very old people. Characteristic lesions. There are different forms of the disease, but the classical psoriasis is characterized by lesions that you must recognize, and they are sharply demarcated erythematous plaque with micaceous silvery white scale. If you analyze them from the histopathological point of view, you will see thickening of the epidermis, tortuous and dilated blood vessels as a consequence of the inflammation, and inflammatory infiltrate primarily of lymphocytes. High degree of inflammation you can see here. If you don't see the inflammatory component, you always have to doubt on the fact that it could be a psoriatic lesion. Genetic predisposition and pathogenesis. The genetic predisposition is very clear because in children, predisposition to develop disease is 20% with one parent affected, 50% with two parents affected, 90% with identical concordance twins. The genes that are involved are HLA-CW6, HLA-CW2, and HLA-B27. That actually is the one associated with ankylosing spondylitis. So the genetic predisposition is really common with spondyloarthropathies. The immune response is the one that influences the kinetic and the epidermal proliferation, both directly and indirectly due to vasodilation. The more blood supply is present, the more keratinocytes proliferate. Some people studying the disease have also recognized some autoantibodies, IgG and IgM, directed against three different antigens. Usually they are not routinely investigated, but if you go in depth with more attention, you can actually recognize them. This is because every time you have an autoimmune reaction, you have all the branches of the response that are activated. And then the manifestation can be due to autoantibodies in some cases, or to T cells or something else in others. So also in autoantibodies. So also in psoriasis, autoantibodies have been found expressed at the level of the plasma membrane of keratinocytes. The inflammation triggers also the destruction of the keratinocytes and their death, and so their death is by themselves source of autoantigens and is able to amplify the autoimmune response. CD4 cells are the ones involved, and the induction of keratinocytes proliferation is mediated by the production of cytokines. Cytokines also trigger the expression of MHC class II by keratinocytes themselves, that amplify the recruitment of the T cells and their local activation in the skin. So somehow the keratinocytes become antigen-presenting cells, and they can eat the other dying keratinocytes representing the antigens. Basically, the skin is becoming a lymphoid organ in which the keratinocytes are antigen-presenting cells. To recapitulate, the immune response mediated by CD4 plus T cells produce cytokines like interferon gamma that triggers the expression of MSC class II by the keratinocytes. At this point, keratinocytes become antigen-presenting cells, and you can have an amplification of T cell response in the skin. You can see this process also in the thyroid, sometimes with autoimmune thyroiditis, in which we have subgerminal centers. Some organs that are target of an autoimmune response are somehow becoming lymphoid organs themselves, because lymphoid organs are where the lymphocytes are. The inflammation at this point is amplified and persists over time. Other cytokines involved in the disease, demonstrated by the utilization of new drug targeting them, are IL-1, IL-8, and TGF-alpha. IL-1 and TGF-alpha are involved in endothelial activation that is really prominent in the skin of psoriatic patients, while IL-8 is a chemokine for polymorphonuclear leukocytes. The cells that respond to IL-8 are perfect polymorphonuclear leukocytes, and probably the cytokines are involved in the recruitment of local activation of PMN leukocytes that, with their ability to undergo activation, activating respiratory burst and producing lytic enzymes, amplify the damage. The inflammation means basically no psoriasis. So if there is no inflammation, there is no psoriasis. In psoriasis pathogenesis, we can recognize different phases. We have a symptomless phase, which is before the onset of the symptoms. That is the period where the autoimmune response develops. We have an acute phase that consists of in the first wave of the lesions, and we have a chronic phase in which we have the relapsing and remitting episodes. During the symptomless phase, we think that there is a homeostatic trafficking of Langerhans cells and uptake antigens in the skin from keratinocytes dying by apoptosis. They go to the lymph node and probably activate memory T cells that are not pathogenic. At some point, however, something goes wrong in this Langerhans traffic, and these cells become activated in producing cytokines that start to damage keratinocytes. At this point, when the first T cells arrive, somehow CD4 and CD8 T cells produce cytokines that trigger all the modifications typical of the chronic lesion, that are the hyperproliferation of the basal keratinocyte layer, the expansion of the blood vessels, so hyperproliferation and expansion of blood vessels. You find this kind of typical hallmarks during the chronic phase of the disease, and the T cells that probably are the major responsible for the onset of the disease are the Th17 lymphocytes that are able to produce the two modifications above. so hyperproliferation of keratinocytes and expansion of blood vessels. Clinical variant of psoriasis. We can have different variants, and the severity of the disease is evaluated considering both the characteristics of the lesions, elevation, erythema, and scales, and the total area of skin covered by the lesions. We can have a chronic plaque psoriasis, in which the lesions that we have seen before in the images are representing the most common variant of psoriasis, which is the chronic plaque psoriasis. So this chronic plaque psoriasis is the most common variant of psoriasis. Plaque may also be very big, as large as 20 centimeters. It's a symmetrical disease because it's a systemic disorder with some sites of predilection for the lesions such as the elbow, the knees, the presacrum, the scalp, and the hands and feet and genitals. Particular sites of modification are the nails, and sometimes you recognize the disease just for the nails. There are people that have only arthritis and nail modifications. We need to consider that there is no relationship between arthritis and psoriasis, and we can have the prevalence of one over the other or vice versa. We can have a very limited psoriasis and a huge arthritis, or a very limited arthritis and huge psoriasis. So, these lesions can be very spread in both males and females, with genital involvement in 30% of the cases, and nail changes are very common. The main nail changes are nail pitting, are small points on the nails, very characteristic. Can have oil spotting, onychodystrophy, and loss of the nail plate. It's not painful, but it's something that's very easy to recognize. Evident, you lose dandruff every time, and it's compromising the life of the patient. It has a very bad impact on the life quality of the patient. The patient has a low self-esteem, feeling of being socially outcast, and excessive scale. Then there are minor forms of psoriasis that are gutted psoriasis, which is characterized by numerous 0.5 to 1.5 centimeter papules and plaques, very small but numerous. We have an early age of onset, most common form in children. Streptococcal throat infection is often a trigger. We have a spontaneous remission in children, and often chronic in adults. So, we can still find the typical characteristics of the psoriatic lesion, but the hyperkeratosis is much less evident and diffuse. They are prevalently found in the trunk and the roots of the limbs. Then we have two additional forms that are the most life-threatening ones, and are generalized pustular psoriasis and erythrodermic psoriasis. Generalized pustular psoriasis is quite rare, but can be really dangerous for the patient. They can have both a gradual and an acute onset, and it is characterized by waves of pustules located on the top of the erythematous skin lesions, often after short episodes of fever of 39 to 40 degrees. If the patients have high fever, can lose weight, have muscle weakness, hypocalcemia, leukocytosis, and elevated ESR. Typically in blood tests, you have no alterations, and if we find them, it's because there is some other disease accompanying the psoriasis. The cause is obscure and can be a superinfection of the psoriatic skin, and so the pustulas full of neutrophils that get infected, or an excessive number of neutrophils that, if predominates, can give rise to this pustulous form. There are some conditions like pregnancy that can predispose to the development of this form, and another important thing is the presence of concomitant contact dermatitis, and that you have the onset of this form after the withdrawal of systemic corticosteroids. So pregnancy can predispose to the development of this form. So the lesions are peculiar because you have the typical psoriatic lesion with the adjunction of the pustule on the top of it. Typically, the treatment is with immunosuppressant, steroids, and cyclosporin, and antibiotics are not really necessary because sometimes neutrophil can be recruited for superinfection, but neutrophils can be recruited also for an autoimmune phenomenon, for IL-8. So basically, neutrophils can be present also in sterile conditions, such as familial Mediterranean fever, where you have neutrophils everywhere. Antibiotics, for example, are not useful in these cases. They are useful just in case of a superinfection. Does exist also a particular form of localized pustular psoriasis located at a localized palmar plantar level, and this is more common and is characterized by the lesions with some pustules, but only located in the extremities. Biopsy is diagnostic, especially in these localized forms. Just a thing about corticosteroids can trigger the withdrawal. So, for an example, is when you have a psoriatic arthritis cured with corticosteroids for a long time, and when you start to withdraw them, transform the disease into pustular psoriasis. Erythrodermic psoriasis is present in 1–2% of patients. Classic lesion is lost and the entire skin is erythematous and desquamative with scales. So the entire skin surface becomes markedly erythematous with desquamative scaling. Often only clues to understand underlying psoriasis are the nail changes and usually facial spurring. If we have an acute onset, we should make the distinction between with Stevens-Johnson syndrome we spoke about before during the allergy lesson. In any case, it is not a big problem at the beginning because you use steroids in both cases, but however a differential diagnosis has to be done. Hyperkeratosis is much more evident, sometimes some other erythematosis, but at the end is always the same disease. This form of psoriasis can be quite acute, associated with fever, and it is the one mainly associated with a loss of protein, heat, and hydration because it's destroying the normal anatomy of the skin. Infection complication is obviously very frequent because skin protection is lost. Therapy. For moderate psoriasis or limited forms, we have many therapies available. We are unable at the moment to completely cure the disease, but we are just able to control the lesions, even if generally the lesions are able to be controlled by themselves. So we can just speed up a little bit the healing process. Possible therapies are topical corticosteroids, topical vitamin D3 analogs. They have the goal to ameliorate the development of maturation of keratinocytes. Topical retinoid, same as vitamin D3. Photochemotherapy, more or less have the same role of improving keratinocytes quality. Systemic therapies have the role to control T lymphocytes, oral or parenteral. So topical corticosteroids. They act on the proliferation of keratinocytes and have immunosuppressive, anti-inflammatory, and vasoconstrictive actions. They are the preferred treatment of psoriasis of the folds and genitals, when others are not tolerated topically, and forms pustular and erythrodermic psoriasis. We have topical vitamin D3 analogs, which are anti-inflammatory and immunomodulatory, modification in the number of PMN, T lymphocytes, and cytokines within the lesions. The drug used 2 times daily is effective in psoriasis in patches, especially in combination with steroids or PUVA therapy. Photochemotherapy can be UVB, UVA, or UVB narrowband. Photochemotherapy can be PUVA therapy, so Psolaren plus UVA. First, Psolaren has the role to photosensitize the subject, and then UVA is more effective. In specific settings, it combines the use of photosensitizing drugs like delta aminolevulinic acid in ointment to 10% with red light, 630 nanometers. Also, photochemotherapy to some extent could be immunosuppressant. For example, during the winter, when we go skiing, how often you have reactivation of the herpes virus, because being exposed to the sun, you create a mild immunosuppressant effect. On the other side, we have systemic therapies. They can be oral with methotrexate, which is most effective together with cyclosporine oral. You can have also an oral, that is cyclosporine, and soriatane, which is acitretin. It can be also parenteral with Ameviv, which is elafacept, which is a fusion protein that combines immunoglobulin Fc with the extracellular CD2 binding portion of the human leukocyte function antigen 3, LFA3. It interferes with lymphocyte activation by specifically binding to the lymphocyte antigen CD2 and inhibiting LFA3 CD2 interaction. Can have Raptiva, efalizumab, which is an anti-CD11A antibody. It's a subunit of LFA1 and acts by binding lymphocyte activation and cell migration out of blood vessels into tissues. And then Enbrel, which is etanercept, which is a soluble TNF antagonist. Secondary skin lesions. Secondary skin lesions are categorized as in pustules, scales, crusts, excoriation, erosion, fissure, ulcer, scar, and stria. Many of these lesions were already present in psoriasis, and atrophy of the skin is also to be added as a secondary skin lesion. Pustules. Pustules are primary lesions usually. They can be secondary lesion in the case of a superinfection of a vesicle, otherwise they are primary. There are small circumscribed collection of purulent exudate in the epidermis or epidermal sheath. The form is usually hemispherical and elevated, but sometimes can be flattened, and the most difficult to recognize is the umbilical one. The color is always yellow-green, and sometimes we have also a little hemorrhagic component. Small circumscribed collection of purulent exudate in the epidermis or dermoepithelial sheath. The nature of the content differs from the vesicle and the bubble. The pustules usually arise in a primitive way, but may be elementary secondary lesions if due to the pustular transformation of vesicle. The size can be from point to a p, 0.5 cm. The form can be more or less elevated, hemispherical, flattened, or umbilicated. Sometimes headquartered in a follicle, so it is centered by a hair. For example, purulent folliculitis. Color can be yellow to greenish, and when there is a hemorrhagic component is brown, reddish, black. The contents are pus always, sometimes even blood. Pathogenesis is bacterial, pyogenic bacteria, as in contagious impetigo, secondary infection of a vesicle. However, there are aseptic pustules as in pustular psoriasis. Number can be single or numerous, widespread or grouped. The pustules usually subdivide with the formation of squamous seropurulent or hemorrhagic crusts. Can resituate erosion, and in the case of deep damage, necrosis, a residual scar. Sometimes in a patient, when you describe a lesion, is an evolving lesion that starts from a vesicle, becomes superinfected and is a pustule, and finally a crust scale, before proceeding 12 steps towards being an ulcer with the resolving scar. When you describe an erythema or a rash, you should explain how it is resolving, and you should describe the right definition and condition of the lesion. Scales. When we have erythematous symmetrical skin lesion, there is almost no doubt that we are in front of psoriasis. Crust. Crust is a rough surface of dried serum, blood, bacteria, and cellular debris that has exuded through uneroded epidermis, such as in case of a burst blister. It's mainly located in the epidermis without going deep in the tissue layers, and is the evolution of a vesicle. Here we can see a crust in the ear due to impetigo. Fissure, it's an epidermal crack often due to excess dryness. Usually the fissure can go deeply inside the skin layers up to keratinocytes and can also bleed sometimes. In fact, it is limited to the epidermis, is dry and sluggish, while if also the dermis is involved, it has a red and bloody color and this is intensely painful. Sites are typically fissures are located in the regions that are more typically dry, such as palmar and plantar regions, the corners of the mouth, the nipple, the edge of the foreskin folds, and the anal areas are more prone to the formation of fissures. Erosion, it's a loss of superficial substance. Erosions or scrapes are secondary to blisters, boils, and pustules and subside without scars with the formation of a crust or a macula. Erosions may also arise from a trauma or following scratching as in pruritic dermatitis. In this case, they are also referred to excoriations and have characteristic linear arrangement for scarification produced from the nail. Excoriation is a loss of epidermis following a trauma, but it's also possible to have it with an eczema. Ulcers are a loss of epidermis and dermis, and typically they are so deep that they heal with a scar. It's a deep loss of substance with little tendency to spontaneous regression. It affects the dermis and the hypodermis and regresses always with a scar. Can be primitive, which occurs as a consequence of trauma, physical or chemical agents, trophic disorders, or can be secondary when follows other lesions such as boils, pustules, or nodules. Scar is the deposition of new fibrous tissue and is the consequence of a loss of substance that is so big such that it is impossible to have a restitution ad integrum. The scar is typical uh, of the healing of second intention. When you have many polymorphonuclear lymphocytes, too much tissue destroyed and restitution ad integrum is not possible, the fibroblasts hyperproliferate and at the end you have such a huge production of collagen that you have a very high abundance of tissues. The scar could be both atrophic or hypertrophic, and the most classical example of hypertrophic scar is the keloid, which is common in black people. Stria are lineal areas which progress from purple to pink to white with the histopathological appearance of a scar, which is associated with excessive steroid usage and glucocorticoid production, growth spurts, and pregnancy.